Dr. Anne Wagner is a clinical psychologist and researcher who is committed to helping understand and improve trauma recovery. She is also the founder of Remedy, a mental health innovation community. She serves as adjunct professor at the Department of Psychology in Ryerson University, Canada. Dr. Wagner has been researching the use of MDMA as an adjunct to psychotherapy. One of the things that makes her research stand out in this field is its focus on relationships. As she writes in her introduction text, relationships are fundamental in our worlds, be they present or absent, supportive or stressful. When an individual has experienced a trauma and is struggling in its aftermath, not only is the individual impacted, but so are those around them. So, Dr. Wagner has been working with cognitive behavioral conjoint therapy, CBT for short, combined with MDMA-assisted psychotherapy for post-traumatic stress disorder. In the first study, looking into this fascinating combination of approaches, the MDMA treatment was given to both the person suffering from PTSD and their partner as a method of facilitating not just individual healing, but also interpersonal healing. My understanding is that Dr. Wagner is already envisioning research combining MDMA with different psychotherapeutical approaches, such as cognitive processing therapy. I'm definitely looking forward to hearing more. So please let us give a warm welcome to our last speaker, Dr. Anne Wagner. Welcome.
Thank you. So welcome back after lunch. And I'm actually going to invite us to have our own experience for a moment. So we get to talk a lot about other people's experiences when it comes to non-ordinary states and consciousness. So I thought maybe let's settle in for a moment and have our own, if you're willing to join me. So if you feel comfortable, I'm going to invite you to close your eyes. And I'll invite you to take a deep breath in. And let that deep breath out. And I'm going to invite you to bring your attention to yourself and to let these words resonate for you. May I be happy. May I be healthy. May I be free. And may I live a life with ease. May I be happy. May I be healthy. May I be free. And may I live a life with ease. And now I invite you to bring your mind to someone you love and to send them these wishes. May you be happy. May you be healthy. May you be free. And may you live with ease. May you be happy. May you be healthy. May you be free. And may you live with ease. And now I invite you to bring your attention to us all as a collective. May we be healthy. May we be happy. May we be free. And may we live with ease. May we be happy. May we be healthy. May we be free. May we live with ease. And with one last deep breath, I invite you to open your eyes and rejoin us. So, when we do that, when we send ourselves wishes, when we allow ourselves to be centered for a moment, and we send our wishes out to those we love and those as a collective, I really feel like that embodies for us some of the work that we're going to be talking about now. The idea of using MDMA as a catalyst, as a therapeutic agent in relationships, as well as for treating of post-traumatic stress disorder, which we've already been hearing about so far today. So I'm going to orient us a little bit, both to the talk, but also I got inspired by Eric's start there. And I'm going to orient you a little to me, too. So I am a psychologist, and I started off being a treatment development researcher, predominantly for post-traumatic stress disorder. So what that meant was that I was part of a team and mentored to develop effective treatments, to test them, to run randomized controlled trials. And I come from two sets of fascinating grandparents, one of whom, one grandfather who was a military veteran in Canada, a bomber pilot during World War II, and who worked as the Under Minister for Veterans Affairs in Canada. So I grew up hearing a lot about the need for treatment for veterans, and especially around post-traumatic stress disorder. And then it occurred to me as I was listening to Torsten's talk this morning, I was like, oh, and the other side of my family, my grandfather on the other side was a German pharmaceutical rep. So I was like, oh, that makes lots of sense that pharmaceutical rep, PTSD, anyway, put those things together. So, and then got invited to start this journey into psychedelic work by Rick Doblin from MAPS. So Rick, who you've heard about in these slides, and MAPS being the Multidisciplinary Association for Psychedelic Studies, invited my mentor, Candace Monson, and I to potentially think about collaborating on a study together. And originally how that happened was that MAPS was hoping to collaborate with the Veterans Affairs Administration in the US. And Candace used to work with the VA. And so Candace and I are now in Toronto, working there at Ryerson University. I was a postdoc at the time, and I got invited into her office one day early on in my postdoc, and she says, hey, how would you think about going to Charleston and taking some MDMA? And I say, what? So having your mentor tell you, like, let's go take some MDMA. Like, why? And then was the first question, and then, okay, was the second answer to that. So that was my very first psychedelic experience. I am no stranger to non-ordinary states, having been a yogi and a meditator for a really long time, but not in this context. So we went down to South Carolina, and I got to have the same type of session that Eric described earlier. So I got to have an MDMA session and a placebo session. And Annie and Michael Methofer, who ran those other studies, were my therapists in that context. So I got very lucky with Annie and Michael, who then later became my colleagues and became our co-investigators on the study I'm going to talk to you about. So that experience for me of having that MDMA session, I walked in having no knowledge or experience with psychedelics at all. And that experience was so salient for me as an individual, and that's N of one person. I found that so compelling that I have then changed my research focus to be almost exclusively on psychedelics and trauma. So that for me, I luckily do not live with post-traumatic stress disorder, but for me was one of the most salient therapeutic experiences of my life, and definitely raised the point, I'm like, this is definitely worth investigating, and especially being a couples researcher, I'm like, oh, this could be really powerful in relationships. So that's an orienting to me and how we got here. So then an orienting about what else I'm going to talk about today. So we've heard about the use of MDMA specifically around PTSD treatment, and we are going to continue talking about that, but I'm also going to lay the scene for the expanding of use of MDMA in therapy. We're going to talk briefly about the history of MDMA's use in couples therapy, and then a little bit about the psychological effects and psychotherapeutic mechanisms of action that might be happening when we're thinking about using MDMA as an adjunct to psychotherapy. We're going to talk about combining the use for PTSD with a couples therapy modality, and then the benefit of adding MDMA to an already established treatment, which is different than the way it's been used previously. We're going to talk about the frame of couples therapy, and then the outcomes of a pilot trial that we ran. And we're going to talk about potential for the true demonstration of healing with MDMA. So expanding the use of MDMA in therapy. So as we mentioned in that introduction, I really feel that relationships are fundamental in our world, be they present or absent, supportive or stressful. We are always in relation with other people. And MDMA's empathogenic qualities, so specifically the ability to foster tolerance and acceptance of emotions, the ability to support communication, and the support of feelings of connection, therefore make it a potentially powerful tool to really work with relationships. And so this burgeoning area that we're seeing is not new. This is far from new, in fact, because there's been a history of use of MDMA in couples therapy right from its beginnings. So we saw that MDMA has been used as an adjunct to therapy until 85, when it was scheduled, and then underground since then. But then also some of its very early use was in couples therapy. So Sasha Shulgin, who you heard talk about before earlier today, so Sasha was a chemist who reinvigorated some work on MDMA. And Sasha's wife, Anne, was considered what we call a lay therapist. So she didn't have a training in being a therapist, but is an exceptionally skilled therapist. And so Anne and Sasha would use these medicines for themselves to test them out. And they thought that MDMA would have such potential power that they started using it in couples therapy. So I had the distinct pleasure of getting to talk to Anne earlier this year and talk to her a little bit about the work. Anne's now 89, something like that, close to it. And she gave a talk about the shadow. And so the shadow being this aspect of ourselves that we often don't want to come across or don't want to interact with. And that really in psychotherapy, a lot of what we're doing is trying to get closer to that and a closer look at that. And then particularly with psychedelics, you get a very close look at your shadow if you're able to work with it. And so to use that in couples therapy can be an incredibly powerful tool if you have two people who are working with that and then have to integrate that experience afterwards. So some of the psychological effects of MDMA, including acceptance of self and others, empathy, tolerance of emotionally upsetting materials, the ability to address upsetting material without extreme disorientation, what I call this ease of cognition, so you can get to the end of the line of thought really quickly and without a lot of difficulty, and decentering or changed relationship to thoughts and memories, and increased openness to experience. All of these things together are really important and impactful things when we think about not only the psychotherapeutic possibilities, but also how it could be used if you have two people together. And so all of those things are ways in which, when I started to think about after my own session, going, how are we going to use this, were things that came to mind and have been coming out over time, both in the literature, in anecdotal reports, and now we're seeing more and more in quantitative work as well. So some of the work that's being done now is to try to figure out, from a psychotherapeutic perspective, what are some of the actions that are actually happening? Why does change happen with psychedelics and MDMA? So there's several different theories that are starting. A lot of these are built actually out of the psilocybin work that's been happening. A lot of it's out of Robin Carhart-Harris's lab and some teams there. But we have several different ideas that we're starting to work with about different potential psychotherapeutic mechanisms of action. So one is this idea of a reduction in experiential avoidance. So when we are faced with something that doesn't feel good for us, we naturally turn away from that thing. And particularly when we're thinking about trauma or PTSD, there are as many people as there are in the world, there's different ways we avoid things. So if we experience something, the idea that we can turn away from it keeps us, quote unquote, safe. However, when we're thinking about reducing experiential avoidance, that's what allows us to get closer and to approach the things that we need to in order to have healing. So one thing that psychedelics can do is potentially reduce the experiential avoidance in the moment in that psychedelic session. So you get that experience of not avoiding. Additionally, there's this idea of reduction in arousal, or the optimal arousal in the window of tolerance. And so this idea being that MDMA in particular can keep you in this kind of optimal state where you're not getting over-aroused or under-aroused, and therefore able to stay with information. We saw this paper flash up during Eric's talk, the Rebus model, relaxed beliefs under psychedelics, which is another potential idea that's going forth. And this supports this cognitive model that we're talking about, that these previously held ideas that you might be stuck in can potentially be relaxed during the experience of a psychedelic or MDMA. And then this model that Roz Watts and colleagues are putting forward, the ACE model, is coming from acceptance and commitment therapy. And it's this idea of accepting, embodying, and connecting. And this that she's developed out of the psilocybin work with depression, but I think can be expanded and brought into the fore with MDMA work as well. So with all those things in mind, lots of theory, what we've been thinking about within the couples work, and we're still developing this idea, is potentially developing a model that is for couples work specifically. So you're the very first audience who gets to see my inner workings of my brain as I try to figure this one out. So this set model, again, is nothing new, right? None of these things are new at all. They're just a re-explanation or a rejigging of different ideas that are coming forward. So the set model being setting, experience, and template. So the setting being that we need to be sure to be using the psychedelic in a therapeutic supportive setting with adequate support, comfort, and trust. And especially when we think about couples work, to be able to be fully immersed in that complete experience. With experience, allowing the experience to occur fully within the container of the therapeutic space and safety of the setting. So having the experience be fully shared in its preparation, occurrence, and integration later. And that's key with the couples work. So no part of the work is done separately. It's all done together. And therefore, to be able to be prepared together for the experience that you might be having can be very, very useful to be able to go through that experience and explain it and make sense of it later. And then T being the template. So I've been using that term template when we're thinking about why we might, for example, be using a cognitive behavioral model alongside couples work. That the idea of a template of an experience, both to frame the actual work you're doing, but also the template of the learning that happens within the MDMA session, can be so powerful. And so that you can use that template for future use in terms of being able to understand or make sense of what's happened. And within that, we have another set, which is structure, exploration, and trust. So the structure being that allows for the structure of therapy together to provide the template necessary to actually dive deeper. And I'm going to talk about that in a minute, but the idea of being able to use the structure or a template of something to be able to actually do deeper healing work can be very, very powerful. The idea that you have something to hold on to or tether to, that you're able to go like, right, we know how to communicate about this, but we weren't sure how to do that before, so we can actually investigate further. Exploration, meaning encouraging the true exploration of whatever is there and whatever comes up. And that the trust piece is trusting that whatever is coming up is being there, happening for a purpose, and that we can work with it, whatever comes up. The idea that there's no bad trip, right? We're going to use whatever comes up as potential therapeutic catalyst. So, that being said, you can now let go of that model and we can look at what happens next. So when we're using this combination for PTSD and couples therapy together, so we're using couples therapy to treat PTSD, I should say, that the individual and those surrounding them are impacted by trauma. It's not individual, right? It doesn't just happen or is experienced by the person with PTSD. It impacts everybody. So therefore, treating the aftermath of trauma in the context of relationships has strong potential power. So you're really approaching the healing of trauma as a system, as opposed to just the individual. Because oftentimes when we see people coming in for trauma treatment, their loved ones are struggling almost as much as they are, right? Or potentially in other ways even more so. And so the idea of one person is having massive change, if someone gets really well within their PTSD treatment, but then the other person is not necessarily having that change, that can be detrimental to everything that's happening. So as a quick reminder, for those who maybe aren't familiar with PTSD, these are the major symptom clusters that happen. And the reason why I'm pointing this out is because sometimes I get the question of why would you be doing a cognitive behavioral treatment with MDMA? And the reason for it is because these different symptom clusters are what gets targeted in the different treatments that currently exist for PTSD. So that something happens, traumatic stressor, there's a re-experiencing that happens, be it through thought, memory, dreams, you name it. There's something comes up again about the trauma. Avoidance then occurs, so you might be avoiding internal experiences or external things. There's negative thoughts and feelings that go alongside of it. And then there's changes in arousal and reactivity. So this is this idea of hypervigilance or hyperarousal that goes alongside of it. And so when we're thinking about treatments that work for PTSD, they are ones that get at these different areas and they actually create meaningful change there. So these different types of PTSD treatments exist. There's exposure treatments, there's cognitive treatments, there's eye movement desensitization and reprocessing, EMDR, which is actually in reality a combination of exposure and cognitive work. There's somatic treatments, including neurofeedback. There's symptom management, including a treatment called Seeking Safety, and complementary treatments as well. And they can be delivered as an individual, in couples, within groups. So right now, when we talk about treatment guidelines for PTSD, the most evidence we have so far are for exposure treatments and cognitive treatments. So that being said, MDMA-assisted psychotherapy does not have enough evidence yet to be included into those categories. What we see is that it's extremely promising, and I will guess that it will be up there quite soon. But what we have so far are the ones that target behavior and cognition are the ones that have the most evidence. So when we think about combining things that already exist, potentially with MDMA, that's why we'd want to be targeting these treatments that are already being used, that already work for a section of the population. So when these best case scenario treatments work for about 50 to 60% of people when they're used. So that's good, but that's not good enough. And the mechanisms that we know are specific to healing trauma include non-avoidance, so not avoiding things that you want to, even though it feels good. We all know we like to avoid things that don't feel good. And that makes sense at the time. At the time of the trauma, you needed to avoid that thing, right? If you see, you have that fight, flight, freeze reaction happening, if you see a bear in the woods, of course you want to avoid the bear. You want to leave. You want to get out of there. But going forward, our alarm system's still going off and saying there's still a bear in the woods. And in reality, there isn't. So non-avoidance being really important, as well as meaning making. So encouraging cognitive flexibility of areas where you might be being stuck around why the trauma happened, its aftermath, what that means about you, the world, and other people. Enhancing the relationship, that goes a long way in terms of healing for trauma. And longitudinal studies over time, when we're assessing the impact of trauma and PTSD on relationships and social support, we see that with less negative social support, so less difficult interactions, you actually have less PTSD. But then over time, PTSD can actually erode your social support. So the idea that if we intervene and we help the social support along, that we're actually going to be helping people with their PTSD too. So what do we need to work on here? Treatments do not work for everyone. We need to create options and choice in different treatments. We need to know for whom, why, and when does something work. We need to bring in the system that's impacted. And can healing be even more profound? So we see some changes, so things like, some PTSD symptoms will go down, but could we see more? Can we see fewer symptoms in other domains and for other people as well? So this we've talked a bit about so far, so I'll go briefly through this. So MDMA has been used in treatment for PTSD. These are some of its actions on different hormones and neurotransmitters. And up until now, it's been used with non-directive, or now we're calling it inner-directed, supportive psychotherapy, which means that that manual that exists through MAPS is a good manual. And what it does is it's calling on the best skills of the therapist. So assuming the therapist has the best skills that they have to bring to the table. Now, that's one therapeutic modality that we could be using with it. What we're doing with some of the work I'm doing, and that I'll be presenting as we go forward, is that we're combining it with another therapeutic modality, so a different treatment that goes alongside the MDMA. As we know, MDMA-assisted psychotherapy has received breakthrough status, and then all of the studies that have happened so far with it, with PTSD specifically, are either proof of concept or drug development studies. And so those look a little bit different than if you're doing a study looking at a psychotherapeutic mechanism of action, which means that we're more focused on the outcome to demonstrate the drug effect on that it will reduce the PTSD symptoms. And now we're changing a little bit more to, okay, what's the combined effect of the therapy plus the drug? So, benefit of that if we're adding it to a previously tested treatment. So, cognitive behavioral conjoint therapy, that's a mouthful. It's a couples treatment for PTSD, CBCT for PTSD, was developed to work with dyads, so two people, in the context of trauma recovery. So it is predominantly used with romantic couples, but it does not need to be. It can be any two people who are intimately affected by PTSD. So it could be a parent-child, it could be siblings, it could be any other, even close friends. It could technically be used as long as it's impacting the two of them. And so CBCT for PTSD is shown in a number of studies, decreases in PTSD symptoms, increases in relationship satisfaction, and improved partner functioning in numerous trials. So one thing I'm going to highlight here is increases in relationship satisfaction. Not always, when we do a couples treatment, is a good outcome improved relationship satisfaction. Sometimes a good outcome is the end of a relationship. We don't normally like to talk about that when we think about, oh, couples therapy made me better because it made me break up with my partner. But that's actually a very helpful outcome in a lot of cases. In this, we still have vestiges of the idea that staying together is the best remedy. Not always the case. However, in couples where it does make sense, when you can improve the relationship satisfaction, that's a wonderful outcome too. And with MDMA-assisted psychotherapy, we also see large decreases in PTSD symptoms over multiple studies. So therefore, in an attempt to facilitate deep healing in the context of relationships, we combined CBCT for PTSD and MDMA in a pilot study. So the frame of the couple therapy is that we believe that having a structure is helpful for couples. Because the idea of going into a psychedelic or an entactogen experience and not having a framework to be able to talk about it with your partner afterward could be very challenging. So it's creating a safe and mutually understood framework. We're giving skills and tools that could be helpful within that, particularly around communication and disclosure about the trauma, because that's a big component that people often aren't talking about, is the trauma itself. So we support being able to talk about the trauma together. We don't have expectations for the MDMA session. We have them set intentions, but no specific expectations. And we use non-directiveness during the MDMA sessions. So we're not actually doing anything structured in those sessions. That we're really allowing for that to be a place for a healing process to emerge naturally, and for an innate place where the client can really bring their own learning and trust in. So the cognitive flexibility piece we're highlighting here with the CBT model for couples, and we're allowing for whatever experiences in the body occur as well. And oftentimes CBT is said it's cognitive behavioral, and you're missing out on the emotion and the bodily sensations. It's just in the name. We actually talk and deal with all four components as opposed to just cognitions and behaviors. And then we're integrating what's happened in the MDMA sessions through the use of skills and tools afterwards. And we're creating a scaffold to tether experiences too. Inherently, couples treatments have multiple outcomes, so it's really important to remember that. And really what we're trying to do in these studies is bridging the world of randomized control trials with depth psychology. And so depth psychology being this idea of going deeper and further into experiences that could potentially be transpersonal in nature or otherwise. And we're going to use this as an example. So CBCT for PTSD, what is it? It's a 3-phased treatment. It's usually done in 15 sessions, weekly sessions. In phase 1, we use psychoeducation and safety building. So you're learning about trauma, you're talking about what it looks like in the context of your relationship, and you're working on tools, for example, to help you out when you become really angry or irritated, which is very useful in the context of PTSD. In phase 2, you're moving into a relationship enhancement and reducing avoidance. So this is more behavioral. So you're asking folks to practice skills, like communication skills, and then you're asking them to start approaching things that they've identified that they avoid. So that's the next step. And then phase 3 is you're working with challenging thoughts. So this is where people may have gotten stuck in the meaning making around the trauma. And so what we did when we're creating this study was that we wanted to strategically place 2 MDMA sessions into that protocol. So we ran this pilot study with 6 dyads with 1 person that had PTSD. And both participants received between 75 and 100 milligrams of MDMA. So the first session, they had 75 milligrams with an optional supplemental half dose of half the original amount. And then the second session, actually everyone went up to 100 milligrams. They had the option of staying at 75 if they really, really wanted to, but everyone went up to 100. And then you have an optional supplemental half of that dose again. And we had primary and secondary outcomes looking at PTSD, both from a clinician report as well as self-report and other report. So your partner's also reporting on the PTSD symptoms, as well as the couple satisfaction inventory. So this is what the protocol flow looked like, and I'll walk you through. So the stars are your assessment time points, so when people are getting assessed on their symptoms. So we had it at baseline, we had it at mid-treatment, at 1 month after the end of treatment, which is their primary endpoint, 3 months later, and 6 months later. So what we did is we did 2 preparatory sessions initially, and that's explaining what's going to happen, getting consent, and then also explaining CBCT and MDMA. Then we had a big day of in-person CBCT. So we condensed down multiple sessions of the protocol that would normally be weekly, and we put them into one big day of CBCT. And then the following day, we did a little bit of CBCT in the morning as a bit of a primer, and then gave the MDMA. And then the session, they had the full day on the MDMA session without doing the CBCT. And when I say not doing CBCT, there was nothing structured. If someone really got stuck and needed support in trying to work through a stuck point or an idea, then we would potentially offer language that we had used earlier, or some of the concepts we'd used, but we weren't actually making them do any exercises or do communication skills. Then the next day, we had integration in the morning, which meant that we were talking about the experiences, what they'd taken from them, what they wanted to continue to remember. And then over the course of the next 3 weeks, we did 4 CBCT sessions. And so we happened to do them over telehealth in this case because we were running the study in South Carolina in the States, and I live in Canada. So I was going back and forth through MDMA sessions, but we did telehealth sessions for the ones in between. Then we did the mid-treatment, more in-person CBCT the day before, second MDMA, integration, and then 4 more CBT sessions to finish out. So we did all of that over the course of just over 2 months. They're getting this intensive treatment for PTSD. So what does the MDMA session actually look like? You're maximizing the time spent inside. Inside, meaning with eye shades on and headphones on. And what's happening there, in the headphones, there's music playing. It's usually instrumental music that's supportive of the experience that's emerging. And at times you're coordinating the conversation between the partners, which is more of a challenge at times than we originally noticed, because what will often happen is people will get excited, especially when it's the partner with PTSD who sits up, takes off their eye mask and wants to share about their traumatic experience. Their partner is like, oh, eye shades off, being like, I've not heard about this, I am so thrilled. And so they're right in there with them. But what we learned to try to do was allow everyone to have their own experience inside and then coordinate the conversation for when they're both ready to talk. And so that was important for us to learn how to be conductors a little bit better in that session. And we're allowing for whatever comes up. And we're supporting non-avoidance of embodied and experiential learning. So whatever came up somatically, whatever emotions were coming up, we're supporting and encouraging of that. Okay, so what did it look like? What are the results? Okay, so the 3 things you've got listed here. So the CAPS-5 is a clinician-administered measure. So that means an independent rater was doing that assessment of PTSD. The PCL stands for the post-traumatic checklist. And so that is a self-report. So the patient is rating, and then the PCL, the partner is rating the person with PTSD symptoms. So you'll see here, these are the means. So the CAPS started at a 43. This is the CAPS-5, which generally, it is CAPS-5. It generally has lower means than the CAPS-4 and some of the other data you would have seen. And we saw a mean of 43 at the beginning, post-treatment mean of 16, and the Cohen's D, so Cohen's D meaning the effect size calculation, is 1.95. And so the issue with this, of course, is this is a group. This is 6 couples. So, I'm getting the 10-minute sign, hence my nodding over this direction. So Cohen's D of 1.95. So that's a high. Very high effect size. So anything over 1 is considered very large. Close to 2 is extremely large. So that's very promising. And then the PCL patient, you'll notice that is even higher. So their self-reported mean at the beginning was 61.5. At the end was a 20, and which is less. So the cutoff in the PCL for probable PTSD is in the mid-30s. And the Cohen's D is 2.13 for that. And then the partner, they're also seeing big shift. You'll notice they rated the partner lower at the beginning, so about 48, going down to an 18, Cohen's D of 1.5, very high. And part of what we're doing at the beginning of treatment is having folks have a shared understanding of what actually PTSD looks like and how it's impacting the relationship. So you'll see that their measures actually get more in line by the end, which is something we actually really try to focus on. And then for relationship satisfaction. So this is interesting. This is only calculated on a 1-item measure right now. So this is the item. On the scale below, please circle the number that best indicates the degree of happiness, all things considered, of your relationship in the past week. I like this question because it doesn't mean like, oh, are you going to stay with your partner forever? Or this is the direction this is going to go in. It's like, no. How happy are you, whatever form your relationship is in right now? And 0 is extremely unhappy. 6 is perfect. So 3 is the midline at happy. And you'll see that for the patient and the partner, they both started less than happy was our mean. We did have some couples who were already in the happy range. So you don't need to be distressed to be doing this. And then everyone was over happy, so not over happy, they were over that cutoff of being happy at the end of treatment. So 3.83 being the mean. And we have a very large effect size for the patient and a large effect size for the partner. So what does that mean? Safety concerns, we had no serious adverse events in the study. This is especially important too because we are dosing for the first time in a clinical study, FDA approved, someone who does not have a diagnosis of anything. So we thought we were going to get huge pushback from everybody about trying to dose somebody with MDMA in a clinical trial who did not have a diagnosis. They did not seem to care because we were so focused on the PTSD. So that was good. We had no dropout, and it was feasible. We did it. We did it in condensed delivery of this protocol. It's normally weekly. We smushed it into just over 2 months. We had big dosing days of the therapy alone, plus MDMA days. And we did some of the sessions over video. So we used a lot of different modalities in this one pilot to try to get this thing to happen, and it worked. And then if we look at other CBCT studies, so this is other studies of the couples treatment without MDMA, the CAPS range effect size scores are from 1.09 to 1.82. We had 1.95 in ours. The PCL patient range tends to go from 0.64 to 1.61, so we are far above that with 2.13. And the PCL partner goes from 0.49 to 2.18, and we're in the middle there of 1.51. And then compared to other MDMA studies, so from the phase 2 studies, granted, this is not the collective, this is just pulling from Michael's paper in 2018, but the general 75 milligram condition had an effect size of 3.38. That's very, very high. But then the 125 milligram condition had 1.65. So we're in between those two there. So we'll see, these are also low N studies as well. So really we need to see how it shakes out over time when we have more and more people doing these studies, and especially with phase 3, we're going to see far more therapists who are offering these studies in far more settings. And that's really, really important to notice, because when you first develop a treatment, it's the experts who are giving the treatment, right? So you're inevitably going to have therapist effect too. So I often would joke, I'm like, is it the Annie and Michael effect, or is it the treatment itself? Because Annie and Michael are really skilled therapists. And so the idea that it could be multiple different people offering this at different ranges of skill, different ranges of experience is important too. So what do we think is happening? Still figuring it out, but what we think might be happening is that there's a learning experience of not avoiding. That's really powerful, and people are talking about it afterwards, saying, you know, I wasn't scared to sit with that memory. I wasn't scared to sit with that emotion. And then there's a template experience of sitting with emotions. They're having more cognitive flexibility, reduced rigidity in their thoughts. That you can see immediately. They're not stuck on this one way, this black and white way of thinking. There's reduced inhibition in the session, so people are able to openly talk about their experiences, which they may not have done before. Notably, we don't ask them to talk about their trauma in the MDMA session. They're doing it spontaneously. We notice, especially in those sessions, there's a reduction in dissociation and numbing symptoms. Those are really hard to get at clinically outside of that. They're usually the hardest symptom clusters to get down. So the fact that people have reduced numbing in those sessions is really powerful. And we're wondering if that's related to the increase in empathy that's happening. That there's a decentering away from experiences, so it's not this idea that you're being fully stuck in with what's happened to you. You can pull back and look at it from a different lens. There's increased self-compassion, and the fact that it's an evolving process, so it doesn't just stop once the treatment stops. The people are continually learning and growing afterwards and changing. And so I pulled a couple of quotes from some of the sessions, actually, when people were talking about what was happening in their experience. And so one participant was asked, we asked this question of, what do you think it would feel like if PTSD wasn't present for you? And this is during an MDMA session. He's like, well, you know, PTSD isn't here right now. Completely unprovoked. And so that idea, that gives you that sense of, it may for a moment give a sense of what it would be like if PTSD wasn't there, if you could make sense of the world without it being present. And this is from one of the participants afterwards. So I feel like the weight is lifted. We started unraveling the strings that had been in knots one at a time. Then the whole knot came undone. I feel different and it feels great. I never imagined there could be this much healing. And thank you for giving me my life back and helping us with our marriage. I just have overall inner peace. It's amazing. There's no price anyone can pay for that. So those are just snapshots from bits of tape I took from the tapes of the session. So we haven't actually gone back all through all the nice quotes that are there yet. But this study conclusion really is that this combination intervention may provide a strong, intensive treatment option for dyads. And future directions are that we want to test it with a larger sample and compared to CBCT with a placebo. So really, we're looking at doing a randomized controlled trial is what we need to do next here. And we have another pilot study that's going to be happening not with the couples treatment, but with another evidence-based treatment for PTSD called cognitive processing therapy, very similar to CBCT, but for an individual. And then the plan is to do the randomized control trial, and I'm very happy to share that we just got our first funding commitment for that 2 weeks ago. So it's going to happen. We just need a bit more money to make it happen. So where I want to kind of leave us here is this. I think this couples work can really help highlight the true healing potential of MDMA. We have the outcomes of the trial that are quite compelling thus far, and it's illuminating the possibilities moving forward of dyadic frameworks, as well as protocol-based interventions with MDMA. So there's an option, I think, and we would really do ourselves a service by trying different treatments with these different tools, MDMA and other psychedelics included, to see what really could be the best outcomes. And then being able to demonstrate with clinical and non-clinical participants that we're seeing change. This is really important. Again, I'll highlight, we dosed people who did not have a diagnosis. And so the possibility here that the impact of relationships affects everyone, and therefore it could be the doorway to broader use of MDMA and psychedelics in the realm of healing and growth and beyond psychiatric diagnosis. So I see a path forward where potentially this data and this evidence can show us that we can see changes that aren't only tied to psychiatric diagnosis, but rather we could see the potential of this use, and this being the doorway to showing that use and showing the safety for that and the feasibility of that for everybody in their healing and growth. So that's my hope going forward with that. So this is me, and a big thank you to my collaborators on this project, Candace Monson, Michael Mithofer, Annie Mithofer, and the MAPS team for helping make it happen. So thanks.
Thank you, Anne. Wonderful presentation. This also could have gone on for 1.5 hours or two. Actually, we'll start with a question from Dr. Passie, because he wanted to present the question.
Great.
Yeah, you offered a slide about comparison with other strategies in treating couples.
Yes.
I'm just interested in the number of sessions. So if you take all the time together which the MDMA patient have to with a therapist,
yeah,
as a couple, and compare that to the other treatment options, are they on a more longer? I mean, do they have more session in a certain time frame, or? And this question is somewhat critical about the what I would call post MDMA euphoria, which might extend to, especially with drug-naive patients, to some weeks. And so there might be effects from that. Might be positive effects, but it might also kind of compromise the results in the long run, so that you get an illusion of betterment in the first place, and then might be later. But the critical is the time frame and the number of sessions.
Yes. Okay, so I'll try to go at the different parts of that question. It's great. So the amount of therapy that people are getting when we're using CBCT plus MDMA is only a little bit more than they are getting with CBCT alone. So partly how I frame that is that they're normally, when they're getting CBCT, they're getting 75 to 90-minute sessions weekly over 15 weeks. And so you get that spread of time and contact with the therapist. Now, when we're condensing some of the sessions of CBCT, we're losing probably about 3 to 4 hours of therapy there, but then you're adding on a 7-ish hour session with the MDMA. So you're getting probably, realistically, maybe about 8 more hours of therapist contact when you're doing an MDMA plus CBCT. So that's the difference. You're getting a little bit more therapist contact there. Now, in terms of the question about the length of time and the kind of MDMA euphoria effect, so we spread, so MDMA session 1, then you've got 3 weeks before your second MDMA session. So that middle time, you're definitely still very much integrating, processing what's happened in the first one. Second MDMA session, you've got a month until you're done treatment. So you're maybe starting to come out of that kind of euphoric experience. Actually, what we saw, you're definitely out of it by then. But and then our primary outcomes is actually a month after that. And then we're doing a follow-up at 3 months and 6 months. And our people continued actually to improve, and especially in their they continue to improve and report improvement afterwards up until 6 months. So we don't know beyond 6 months. We haven't tested beyond 6 months, but up until then, we're showing either continued improvement, stable improvement, or continued afterwards. Yeah, thanks.
Is MDMA addictive?
Is MDMA addictive? Okay, well, so I'm going to, from the perspective of a psychotherapeutic researcher, I am not a pharmacologist, but none of the participants in our study indicated that they took any more MDMA afterwards, nor did they want to take any more MDMA afterwards. And that's really important when you're thinking about it in a therapeutic context, because it's not easy doing these sessions. It's not euphoric. And you hear this quip all the time of, I don't understand what people call it ecstasy. People often say that in the therapy sessions. They're like, I don't know why they call it ecstasy. Because it certainly does not feel ecstatic. You might have moments of relief, of calm, perhaps of bliss or joy, but they're moments within your experience as if you have PTSD or if you're the partner of someone with PTSD. So in these ways, people see it as a very intense therapeutic journey on those days and afterwards. And so they're not, itching to have more experiences. So in that way, I would say it's very much not addictive. Yeah, that's where I got for that question.
Yeah, maybe you might say that certain contexts of taking MDMA can be addictive to people.
Yeah, I mean, I think certainly if people are using MDMA in different contexts, there will be different impacts of that use, and also, that experience. If you've had a positive experience in one context, you may be looking for that positive experience again. Or if you've had a useful or helpful experience, you might look for it again. But we're really talking about the strategic use of MDMA within a context of exploration and healing and growth. And so in those contexts, sometimes people talk about, I've heard in other studies saying, potentially a year or two down the road, I could see having another MDMA therapy session. But that's a very different experience than taking MDMA recreationally. Recreationally, MDMA in another context. Let's put it like that.
So a question regarding your doctoral dissertation, which was about the attitudes and beliefs about people with HIV.
Yeah.
And the question is, do you see similar social stigmas with the users of psychedelic drugs?
Cool.
As with people with HIV?
Who looked up my bio? Okay. So my background is in HIV work, and I've done a lot of work with community organizations, LGBTQ groups, and my PhD dissertation was on the attitudes and beliefs of healthcare providers towards people living with HIV. And unfortunately, our healthcare providers, despite there having been many decades of demonstration of change, let's say, in the HIV sector, there's still stigmatization around it. So I would say, I don't know that I necessarily draw a parallel around those things. I would say I'm certainly drawn to investigate things that might otherwise be very stigmatized and potentially stigmatized by healthcare providers, like substance use. Was there more in that question? I just got really thrown that someone looked at my dissertation.
Yeah, the question was just that, do you see similar social stigmas with the users of psychedelic drugs and people with HIV?
Right. And I think yes and no. I mean, I think there historically has been stigma around the use of psychedelic drugs. I would say we're in a period of change and opportunity around, because of this kind of forward motion that people seem to initially have gotten on board with around this kind of medicalization of psychedelics, and seems to be opening minds a bit further to different uses of psychedelics. So definitely there's been stigmatization in that way. I would say stigmatization in the HIV sector comes from different areas, but there's also, not unsurprisingly, an intersection around drug use and HIV stigma that exists. So I think some of our same stigma reduction strategies across the board are useful.
There was also a clarifying question. So the effect sizes you showed us about the CBCT and MDMA study, as well as the ones from Mithofer's study, are within the treatment group, not including control group.
Okay. Yes. So that's a good point. No, this includes the control group. So that is the treatment, the across group treatment effect size. So for example, we're not, it's not within subject, it's between subject effect sizes. Help? Yeah, okay.
And also, is there a reason for the standard deviation being so much bigger in post-treatment measures than pre-treatment?
Yes, good question. Let's bring that up. Yes, there is a big reason. Initially, everyone had PTSD. At the end of treatment, one person still had PTSD. The rest did not. So you see one person's score is very much inflating the standard deviation in that post-treatment measure. Good catch, whoever saw that.
MDMA for couples, an obvious practical question, teratogenicity. So the harmfulness for embryo or fetus.
Oh, yeah, no, don't take it when you're pregnant.
Yeah, I know that at least in the studies that I've looked into, it's an exclusion criteria that you're pregnant and you need to prove that you're not pregnant. At least
that's right.
Studies,
Yeah, I mean, we don't have, vast majority, studies have not been done on folks who are pregnant taking MDMA because we don't know all of the effect on the fetus.
Also, recreational users, they are in the hundreds of millions, and they haven't shown any teratogenic effects so far. So, just want to mention that.
Thank you. Okay, yeah. So Torsten was mentioning that in folks who are using it outside of therapeutic contexts, there's been millions of users over time, and that there hasn't been any reported teratogenic effects there. Yeah. So yeah, it's an exclusion for the research studies, simply because it hasn't been tested, but in the general information, we don't see teratogenic effects.
One more, difficult to decide. Are there exclusion criteria in MDMA-assisted therapy for couples, such as abuse within the relationship?
Yeah, so that's a great question. Now, so within couples therapy, we see the absolute range of different abuse experiences. And that's important to think about the safety in the context of the relationship and how close in time a serious conflict has occurred. So we don't exclude based on the fact if there had been any abuse in the relationship. What we do exclude on is how regulated in the moment that is. So meaning, is there any what we classify severe abuse experiences within the 6 months before they're enrolling in the study? And that's simply because, first of all, abuse experiences are extremely common in relationships, and we were trying to mitigate the risk that would potentially get inflamed in the therapy. However, we obviously see lots of conflict that comes in. So, and we do allow in folks who've had what we classify as not as severe experiences, and we target that in the treatment. At the end of the day, I think that this could potentially be useful for even folks who've had conflict and abuse experiences in the relationship closer to that period of time. At the pilot stage, we're trying to at least mitigate a couple of factors, but I think over time that we could see something different with that.
Okay, thank you very much, Anne.
Thank you.